everybody. Thanks so much for joining us today. My name is Nicole Lamberson, and I was trained as a physician assistant. I'm a member of the outreach team for the film Medicating Normal, and I host conversations like this one today. Our guest today is Jim Wright. He obtained his MD from the University of Alberta in 1968, his FRCPC in internal medicine in 1975, and his Ph.D. in pharmacology from McGill University in 1976. He was a practicing specialist in internal medicine and clinical pharmacology and has recently retired. He was professor in the departments of anesthesiology, pharmacology, and therapeutics in medicine at the University of BC in Vancouver between 1977 and 2019. And since 2020, he is Professor Emeritus. He was the co-managing director of the Therapeutics Initiative and editor-in-chief of the Therapeutics Letter from 1994 to 2019. His research focuses on issues related to the appropriate use and safety of prescription drugs, clinical pharmacology, clinical trials, systematic review, meta-analysis, and knowledge translation. So thank you so much, Dr. Wright, for being here with us today.
Thank you. It's my pleasure.
Yeah, sure. So I guess first to introduce people who don't know, what is clinical pharmacology? How's it different from just being a doctor? And what led you to sort of move into that after you had already gotten your MD?
Clinical pharmacology is a subspecialty, and in my case, of internal medicine, and it means that I am an expert in the use of prescription drugs in people, and the average doctor and even internist doesn't really have expert knowledge of the complicated aspects of the drugs that they prescribe. It's unfortunate, but that's actually a fact. They are prescribing mostly based on associating a drug with a diagnosis and then prescribing it, but not with an in-depth knowledge of the drug or the evidence that the benefits and the harms are a proper balance for the patient.
Yeah. So if you just have an MD and say you just stop at being an internist, for example, how much clinical pharmacology do physicians really get in that schooling?
In medical training now, when I was a medical student, we had a comprehensive course in pharmacology, but that was phased out, and medical students now do not have a comprehensive course in pharmacology, so they have to learn, pick up things as they go in terms of they usually, most medical schools use a case-based approach, and then so they would pick up things along the way, but it's not comprehensive, and then there's a lot of holes in it, and they don't really have a real understanding of the drugs and the complicated aspects of the drugs.
Okay. So being a clinical pharmacologist, then, a big portion of your career was focused on the safety and appropriate use of prescription drugs. And you spent a lot of time on hypertensive or blood pressure medication. So I'm wondering then, how did you transition into having interest in psychiatric medications?
Yeah. Well, I was fortunate in that in my career, I had an academic appointment, which meant I was getting a salary from the university. And then I was working with the Therapeutics Initiative, which means I was working with a large number of expert people who were able to look at the evidence. So I was able to appreciate the evidence around the benefits and harms of of drugs to a much greater degree than the average physician. And during that time, I became aware of the shockingly lack of evidence for particularly psychoactive drugs and psychiatric drugs. I became aware that they came on the market with relatively short-term trials, and in those short-term trials, they were only marginally better than the placebo group, but that was judged sufficient to bring them on the market. And then subsequently, they have not been studied in terms of long-term trials. In the hypertension area, there long-term trials have been done. These are 5-year trials where the drugs were compared with placebo, and there is modest evidence that long-term use of antihypertensive drugs in the right population is beneficial, but that is not the case for any psychiatric drug or drug for sleep or anxiety or etc.
Yeah. So we've had these drugs on the market though for such a long time, Prozac since the 90s and the benzos now for 60 years. But no one has ever looked at people in all that time that have taken it for a long term. All we have is those short-term studies, is what you're saying?
That's correct. Yeah. And we use the gold standard evidence, which is a randomized trial comparing the drug with a placebo or no treatment. And so those long-term trials have never been done in the psychiatric field.
Yeah. Wow. So is it just because there's no money in finding out what's wrong with the medications, why they won't look at long-term use, or it's just too expensive? Yeah.
Well, it would require funding from a non-drug company source. So it would require funding by a government source or an independent source. And it would be fairly complicated. I think it's certainly doable, but the people haven't come along to do it. And once I got involved in this, I was too far in my career to really be looking at a trial that was going to last 5 to 10 years.
Right. Okay. So you talked before when we first started chatting about, clinical pharmacologists get a specific expertise in psychiatric medications that most physicians and general practitioners and internists and such don't get. So knowing what you know from, studying the short-term trials and also from your clinical experience working with people taking psychiatric medications and having trouble coming off of them, are psychiatrists, are they sufficiently trained to be prescribing psychiatric medications? Are general practitioners even, because they are prescribing the most psychiatric medications? I mean, when I took them myself, I thought, oh, a psychiatrist is an expert in these meds, but they're who to go to. They're the cardiologist for heart problems. They're the, person for psych meds. But what do you think about that?
I don't think they are, and they would disagree with me probably, but in my opinion, they're not. And I think when this is for people who are in the position where they're considering starting one of these drugs, I think they should appreciate that they should ask for what is the evidence for the use of these drugs, and is there long-term evidence that that the benefits outweigh the harms. And so when doctors are prescribing, if they're being honest, they should say, we only have evidence for short-term use. The benefits are very marginal, And we don't have evidence for long-term use, and so therefore I'm not going to prescribe it long-term for you. I mean, that's the way I would approach it. And that would change the whole situation, because if people were using them only very short-term, they probably wouldn't get into the problems that they have with what we're seeing. And we know now that people are being severely damaged. And we don't know exactly the incidence of that, but it's certainly large enough, and we know that there's enough people out there who are telling us how damaged they've been from these drugs. So it's not a minor side effect. These are serious consequences that could occur.
Yeah. So you had a practice where you actually were taking patients who were having difficulties with psychiatric medications. Was it all psychiatric medications or mostly benzo patients that you saw?
In the beginning, it was mostly benzo patients, and these were people then who had been taking benzodiazepines for some period of time. And then they were trying to come off and having a very difficult time. And so I was being referred to help them. And so I used the Heather Ashton method and personalized it to the patient, and was able to help people over a long period of time gradually come off the drugs and be successful in that. And when I did that, I found that some people, even after they had come off, were still suffering a lot, and so it's not unfortunately over when you stop taking the drugs completely. So that's another sad thing to be appreciating.
Yeah. If I heard correctly through the rumor mill, you got to meet Dr. Ashton in person. Is that right?
That's right. Yeah, she came to Vancouver quite a long time ago, but and I did meet her at that time. Yeah, and
Yeah.
she continued to work well into her 80s, I believe, and yeah, so she's been very influential. The manual is still available. People can get it on the internet, and so it's still being used, and it's not out of date in any way, and
Yeah.
it will never be out of date. So it's a useful
Yeah.
reference. Yeah.
Thank goodness for her, right? That she
Yeah.
put that together, because I don't know where some of us would be without it, really.
Right.
So we talked about, if psychiatrists and general practitioners are, educated enough to prescribe, but what about deprescribing? Since you were doing that, what have you seen? Have you heard from patients reaching out to you, telling you, they can't find anyone to help them? What is it
Yeah.
like?
That's common. Yeah. So it's I think there are now a growing number of people who are getting interested in deprescribing, but it's still a very small number.
Mm-hmm.
And so in a lot of areas, there really aren't any people who are interested in that. It's a time-consuming task,
Mm-hmm.
and in Canada, where we have a fee-for-service system for the most part, the fees are not sufficient to reimburse the people to do it. So I think that's a disincentive for people to do it. So you have to be interested and want to do it in order to do it. And in my situation, I was able to have the luxury of spending more time with patients, because it is they need the extra time to help them get through this. It's a difficult process.
Yeah.
And and I did get into other drugs. So I was working with people who were harmed by antidepressant drugs and antipsychotic drugs, and each one of them has their own complications. So it's it's not something that you can just approach in the same way for all situations.
Yeah. Someone in the audience is mentioning that you're the only physician in Canada listed as being benzo-wise. And of course, now you're retired. So what do people in Canada do? Are they just emailing you and then you have nowhere to send them, essentially?
Yeah, unfortunately now that I'm no longer practicing, I have to just reply and say that I'm unfortunately not able to help them.
Yeah.
Yeah.
Yeah. Okay. So I have some questions just, that I'm curious about, somebody who's been through this myself and who's been in the withdrawal communities. And I think some of the people, that I'm speaking for or representing probably want to know the same thing, but I'm not sure if clinical pharmacology really digs into that type of thing. But I guess you've probably heard of like tardive withdrawal or like a delayed type of withdrawal where people maybe taper or they rapidly cold turkey the drug, but then the withdrawal like doesn't kick in for a couple of months or it doesn't get severe until later. Would you have any hypothesis for like the mechanism of why something like that would happen, or it's one of the great unknowns because no one's really studied these?
It's a good question, and I've been asked it before.
Mm-hmm.
We don't have a way of measuring or documenting the damage that occurs in patients.
Mm-hmm.
I'm hopeful that at some time that will become available, but at the present time it's not possible, and I don't know of too much research in the area, but I still hope that. Yeah, so there has to be some changes in the brain that are occurring that manifest at a later time. We know that the drug would be gone by then, so we don't think that it's the presence of the drug in those situations. But we don't really have a good explanation or a good answer for your question.
Right. Is the answer the same then for, do we know why protracted happens, or do we know why people have setbacks, meaning they heal from benzo withdrawal maybe, and then something happens, like they take an antibiotic and people report the withdrawal is back all of a sudden, they've had some kind of reaction?
Yeah. And I've seen those things as well, but I don't have an explanation for it.
Yeah.
Other than but it does occur, and it's important that physicians are aware that these things do occur.
Yeah. I think that's part of the distress in people who are experiencing them, is that the physicians don't know it or believe it or recognize it. And also it's really difficult to suffer with something for a really long time and have no one be able to tell you why. Why is this happening for 6-7 years when I've stopped taking the drug, but this person over here healed in 2 years. And really what people want to know when they're protracted is it ever going to end? Will I recover?
Yep. And lots of patients had asked me that.
Mm-hmm.
The approach I took was that, yes, ultimately you will recover. I don't know that for sure, but I think having a hopeful attitude is better than despairing.
Yeah. Did you ever have protracted patients that you followed for many, many years that eventually did heal, or you just kind of lost touch with them? Or
Yeah, yeah, I did have protracted patients, and when they get well, then I don't hear from them. So yeah, so it's hard to know. There were some, I think, who have had recovered completely. So yeah.
Yeah. I think in some cases when people get better, they don't ever want to hear about this or talk, it was so
Yeah,
traumatic and horrible that they just want to move on with their life, So,
right.
why do you think patients are having such a hard time being believed by medical providers that they're having all these, difficulties with psychiatric drugs? I've heard you say in other interviews that you believe it's probably a pretty common problem. I mean, we can't put an exact percentage, right, without studying people. But why the disbelief, you think?
I'm not sure. Um, but it's very common. All I can say is that's the um, common information I would get from patients, is that they did not get any support or belief from their previous doctors.
Mhm.
So when I was seeing patients, I would write uh, consult letters to the doctors, and so I would try and educate them. And I think that I was successful in that, but that would be sort of one physician at a time um, as you're going along. That that this is a real phenomenon, and that it is something that we all need to be aware of.
Yeah. And for the most part, when you would write letters, then would it change things? Would the receiving physician, do some more research or change their tune or?
Yeah, it's usually a one-way communication when the physician or specialist to a family doctor.
Yeah.
Um, but at least I think when the next patient comes along, that they are um, they're more open to the fact that this is real. And then
Yeah.
there have been cases where that physician would refer another patient to me
Mm.
further along the line as well.
Yeah.
So I think they did appreciate that to some degree.
Yeah. I think part of the problem is just that it's not in their differential, right? For anybody who doesn't know what that means, like when you're diagnosing someone as a medical professional, your differential is like your list of things that could possibly be wrong with the person. But if you
Yeah,
don't even include the drugs in there, it's like it's not a possibility. They just don't, they don't include it. And so that, from being a patient, that's so frustrating when you're seeing a physician and you're telling them, that I think this is what's wrong with me, and they won't even, put it on the list of possibilities. So,
yeah.
yeah.
And probably there maybe we should be pushing for product monographs in the list of adverse effects.
Mm.
They do say that the drugs can be addicting, but they don't list protracted severe withdrawal symptoms as one of the possible
Yeah. I think they
consequences.
did in the black box update through the FDA, but maybe that's different in Canada. You guys have a different program there.
So is it in the black box now for benzodiazepines? That
I mean, not in, great detail or anything like we would like it to be, but it differentiates between physical dependence and addiction. And it does talk about withdrawal symptoms and even protracted withdrawal. Yeah.
oh good, oh that's
Mm.
good.
Yeah.
Yeah.
So I'm wondering about, this specialty that's come out called pharmacogenomics, or like DNA testing for medication safety. Do you know much about it? And do you think it's legit? Is it the future of medication? What do you know?
I know a fair amount about it. Yeah, it's
Mhm.
and this isn't that new. We've known that people have different um, potentials for metabolizing different drugs, and so
Mhm.
those have been known. But unfortunately, I don't think it explains very much.
Mhm.
So we would like to know, okay, so is a person more or less likely to have problems if they're a particular, if they're a slow metabolizer, et cetera. But we don't know that for sure, and that hasn't been proven. So I don't think it's an answer to situation. It would have to become, there'd have to be some new discovery that there was some genetic predisposition
Mhm.
to harm. Um, it's possible that something like that might come along, and then maybe people could be screened for that, and then in particular, those people should not expose themselves to some of the drugs as well. But I don't think that's something we're going to have in the near future.
Yeah. Because the DNA testing really just tells you about drug metabolism. It doesn't
Right.
say, we know there's some people who take benzos and who can stop them with no issue. We don't know why they can and someone else can't, but the DNA testing couldn't tell you something like that.
No.
Yeah. Okay. Makes sense. Um, so just from a, clinical pharmacology point of view, I think an important topic to educate people on is polypharmacy, which means, people taking more than one medication at once. And it doesn't even have to be 5 psychiatric drugs. It could be, a hypertensive med and 2 psych meds and, other medications. So, in your expertise, how dangerous is polypharmacy? How aware of it as consumers of medication should we be?
Well, the complexities of and the potential for interactions between drugs is really it's almost like if you wanted to try and figure out a particular patient who's taking 5 drugs or 6 drugs, it would take you a month or so to study that on a full-time basis. And so and people aren't doing that and not taking the time. But it is I think when we take any drug, we are especially well. Let's it's really when you're taking a drug on a daily basis over a longer period of time. When that is happening, you really don't have a good idea of what the consequences of that could be.
Mhm.
And when you're taking drugs, psychoactive drugs, then the drugs are working on your brain, and the brain is so complex that we really don't. So we should be very, very cautious about ever taking any drug on a daily basis, long term for in that particular setting. But then when you add in another drug, it even becomes more complex. And when you add in 3 more drugs, it just becomes so complex in terms of what could be happening
Mhm.
that um, it you can identify some interactions, but a lot of the time, even though there is a potential interaction, it doesn't necessarily mean that it's going to lead to bad consequences. So you're really trying to identify what we would call is an adverse drug interaction that is leading to a particular
Mhm.
bad consequence. But most of it is not known, so that's why I think everybody should be extremely cautious when they're taking daily drugs, especially multiple drugs, and it includes supplements. Because a lot of my patients, I mean, I had patients who came in and brought bags full of supplements that they were taking as well, and I would never be in a position to try and figure that out, and the
Yeah.
potential consequences of it.
Yeah. I mean, I can't imagine. I mean, all of the potential combinations that you could
Right.
make, it would be impossible to study,
Yeah. So
and
each person is an individual experiment, right? And so,
yeah, yeah, really. And that's a great point about the supplements too, because I see people who are damaged by psychiatric medication and then they're so desperate to feel better that, you know, something about the supplements gets this label of like natural, you know, it's greenwashed, it's healthy, and they'll go to a naturopathic physician or something and come with a huge list of supplements. And then I've actually seen patients have what we talked about before, those adverse reactions, or they'll even try to come off the supplements and go back into benzo withdrawal.
Yep.
You know, so very good point. Thank you for bringing that up. Do you
So
need
yeah,
to?
so supplements on a daily basis are not a good idea, I don't think. And you can't trust what you read on the internet that it's going to cure different things. But
Yeah.
so yeah, so it's best to stay away from anything that's that you're taking on a daily basis.
Yeah.
The you know, you might ask, well, why would we, what's happening in the world that would get people to be taking things on a daily basis? It's really people making money, because that's how you make money, is when you get people to take things chronically, right? So if it's drug companies can't make money if a person only needs to take 3 doses of a drug to solve their problem. It's just so they want people to be taking things on a chronic basis, and that's what's happening, unfortunately. There's far too many people taking drugs that we don't really know whether the benefits are outweighing the harms.
Yeah, and some of the polypharmacy is so crazy too. I mean, I look back in hindsight at the medications I was prescribed, and it doesn't even make any sense. Like, I was on lots of benzos and also Adderall, and it's
Right.
like, you know, do you see a lot of that in clinical practice as well?
Well, I would see complicated patients, who were we're trying to get off. So it's it's not rational, for sure.
Yeah. Okay. Somebody from the audience says, I guess they're a patient who is discontinuing benzodiazepines, and they want to know if they need to be cautious about anesthesia.
They commonly use benzodiazepines in anesthesia. They sometimes will give people lorazepam prior to the operation to calm them down, and they commonly use midazolam, which is a benzodiazepine. So it's it would be worth, I think, in those settings, and I did do this sometimes, is I did talk to anesthesiologists and said, can you manage without using any of these drugs? And they almost always can. So it's probably better not to even take a chance on that.
Yeah. Okay. And then somebody said, as we wait for our healing to occur, basically from benzodiazepines, should we be avoiding symptoms? Will we not have to eventually go through symptoms anyways as our pathways reconnect?
Well, the whole purpose of tapering is to minimize the symptoms, but not to stop them. People all suffer withdrawal symptoms. So you taper at a rate that is tolerable, but you're not able to prevent withdrawal symptoms. And so you shouldn't try and completely have no withdrawal symptoms, because you are going to have them. I think that's for sure. And and so you shouldn't try and slow it down so much that you don't have any. So you're trying to you're trying to do it slowly, but the more slowly you do it, the longer it's going to take. And so there's so you're always balancing how fast to do it and how to do it in a way that's tolerable.
Yeah. So really control your expectations. So don't expect to have a totally symptom-free taper.
Right.
You're going to have some symptoms. Yeah.
Yeah.
Okay.
And it's good to have a supportive person who appreciates what you're going through, that can support you during that time.
I'm just wondering what your advice would be for, I tell my story all the time, and people kind of, ignore me, or they think that I'm some one-off thing. I think we're so just like used to tuning out, especially in America, the drug commercials, that have the long list of things. But I say to people, like, actually, those things really happen to people. That's why, they're listed there. But I think a lot of people are just naive, as I once was when I took medications daily and thought, oh, like my doctor wouldn't give me anything that was damaging or unsafe. So what kind of message do we need people to get, like, about the seriousness of accepting a medication and taking it regularly? Like, what should people be doing before they just blindly trust and go to the pharmacy and fill something and start taking it?
Well, people do research when they're buying a television or something, right? And they'll often look into different things and go to Consumer Reports, etc.
Yeah.
But it's a much bigger decision you're making when you start a drug on a daily basis, and so you should try and learn as much as you can. And the more you learn, the less likely you're going to take it. That's what I've. So a pharmacologist who really has a good appreciation of the effects of drugs is very unlikely to be taking something on a chronic basis.
And you've said before that you don't take any medications on a chronic basis.
I don't. Yeah. No.
So what do you think that statement says about, like, what you think about medications in general? Just that, what you said before, taking them long term is a very risky, dangerous business.
Yeah. They're as I said, in the field, people with severe hypertension, there is evidence that taking drugs on a daily basis can decrease their risks going forward. So that's one setting, but there's not very many settings where we have good evidence that the benefits outweigh the harm.
Yeah, I was going to say, can you think of any others? Like, are there others we can put on our, like, maybe helpful, safe list, perhaps?
Yeah. Well, there's trials in people with heart failure that drugs can prolong their life. There's not much in diabetes and type 2 diabetes. I mean, the type 1 diabetes is different. Those people need insulin long term, but type 2 diabetes, there isn't really good long term evidence of drugs where the benefits outweigh the harms. And I think a lot of the drugs being used in that setting are causing more harm than benefit. So we need to push for independently conducted, randomized, controlled long-term trials. And there's not that many happening, unfortunately. So we should be pushing the government to fund an organization that would be running those kind of trials.
Yeah. And where is the good information? I mean, you can Google are psychiatric drugs harmful, and you'll get an article from wherever that says they're the greatest thing and everyone should take them and they work wonders. And then you'll find an article about harm. So consumers are really in a bad place trying to figure out, like, where's the truth? I mean, is Therapeutics Initiative, like Cochrane, are those good resources that people can trust?
Yeah. So though they're relatively independent, and so the evidence is better, and they do have standards, and they do look at randomized control trials. And it's hard for somebody to say read a Cochrane review and really understand it, because it's really complicated, and they're long, and they're and then it's hard to appreciate what the numbers mean, right? So I mean, I've been doing this for the last 30 years, so it's not that difficult for me. But if you look at the trials of antidepressants and their effectiveness in the Cochrane, you'll find that the difference between the drug group and the placebo group is really trivial and not clinically important. And so the people, a lot of the people who think they have benefited from the drug are actually having it's a placebo effect, and they would have done just as well if they had received a placebo, which is really an inactive compound and not having any effect. And I think that sort of explains why once the drugs get on the market, they are effective in people, including, and that's where a lot of the supplements come along too. People feel like they have benefited, and again, it's most likely they benefit as a placebo effect, not a real drug effect.
Yeah, I tell people, if you're gonna try a new medication and you're researching, like look and see if you can find a support group for people who have taken the medication before you. But when we're trained medically, I mean, I'll just speak for myself. I'm not sure if you got similar, but they sort of teach physician assistants and doctors that patients can be like poor historians, or you can't really trust, their reporting. But I think now, having been on the patient side and been harmed by medication, that's kind of the first thing I'm going to do, is go look and see what the patients are saying. Do you agree with that? Or
yeah, and I think that's good. Yeah. So you would come to appreciate that there are quite severe harms that could be occurring, right? And so
yes.
Yeah. So then, you and if you look at, say, a Cochrane review, you'll find that the trials are only 8 weeks. And so you should say, okay, well, why would I want to take it longer than that when there was no evidence, right? Or there isn't evidence for longer term use.
Yeah. This is a really good question from the audience, and one as somebody myself in protracted withdrawal grapples with all the time. They want to know if you ever had a patient that was in protracted that wanted to reinstate, and what would that process look like? Would you always encourage them to just stick it out and stay off, or do we have evidence that that's a good plan, or should somebody maybe go back on if they're just feeling so ill and they can't take it anymore?
Yeah, that happens quite often. And when I was dealing with these patients, I would strongly recommend that they stop tapering and stay on the dose they're on, but not go back up. And,
no, but I mean people who are already off. So say they cold turkeyed, or they, they finished a taper, but it's like 3 years later or 6 months later, and they're just like, I can't do this anymore, and they want to go back on the benzo. Yeah,
I would strongly advise them not to, but I have had patients who have done it, and it hasn't worked out well. They did not find relief by going back on, and so then it could potentially complicate things even further. So so I would. It's not the answer, I think, unfortunately.
Okay. When you say complicate things further, are you speaking or hinting at maybe like the kindling phenomenon? Are you aware of that? Yeah.
I don't know if that is real, but I'm certainly aware of that. But so but I think they would be at risk of starting to take it on a chronic basis again, and then they're back where they were, and
Mhm.
it wouldn't solve the problem in the meantime. That's the
Yeah.
other issue, right? So if it would, I mean, I have, some people have said, well, I'm 90 years old, and why not?
Yeah.
But it doesn't solve the problem, so it's
Yeah,
it's
there's
not.
one physician I spoke to. He said that he had read something about benzos have something called remembering tolerance, that even you can be off of them for many years and your system remembers that you were on like 3 milligrams of Klonopin. So you may never get away with a lower dose. Does that sound
Yeah,
like, yeah,
but or the 3 milligrams won't even do what you would hope it would, right? So, and once
great.
you take it daily, you get tolerant, right? And so it loses its effect. I mean, that's the whole problem, right? So
Yeah.
it's not, there's no solution. There isn't any
And so
effective
for
way.
anyone considering taking a benzo, this is, you wind up in this trap, and it's a trap. I've called it a
Yeah,
cobweb before. You're just stuck in this cobweb, and you've got to get off. But then if you get off, sometimes you're suffering so bad and you feel like you want to go back on because you want relief, but then they say it won't work, it won't help. And so it's the worst place to be. Really, it's a horrible, horrible syndrome to have to experience. From that's just me
yeah.
speaking personally. So all right, let's see if we have any more questions here from the audience. This is kind of something similar I've already asked you, but maybe you have a different answer. Do you believe the downregulation of receptors theory? Or if not, how do you conceptualize the harm?
We explain tolerance by down regulation of receptors, but we don't have a way of measuring that.
Mhm.
But I do think that happens, right? So if the brain is designed to counteract the effect of, of noxious materials, and drugs are really noxious materials for the brain. So the brain is designed to adapt and become tolerant to the effects of a drug, and it certainly happens, right? I mean, we know that in many areas, right? So people who drink a lot of alcohol, right, they become tolerant, and
Mhm.
sometimes they brag about it, right? But that's not a good thing
Mhm.
to achieve. So we can, yeah. And if you take a sleeping pill on a daily basis, by day 7, it you become tolerant, and so it's no longer having any effect. It's not helping you to sleep, and you might have a hard time stopping it, right? So it's it's the phenomenon that occurs, and it does occur um, with other drugs as well. So doctors will sometimes say, "Oh, you're if you keep taking your antidepressant, the side effects will go away." That's not a good thing, because that means you're becoming tolerant, and so it's not. It's a way that almost all these drugs are losing their effectiveness over the long term, and why we should only use them short term.
Yeah.
So rescue therapy is still appropriate,
Mhm.
and some people can get quite a bit of benefit from taking a benzodiazepine for sleep, say 2 or 3 times a month or something, just as rescue therapy,
Mhm.
and they won't really get into trouble if in that setting.
Yeah.
And we use drugs acutely in hospital, and can be, so the drugs do have a use in certain settings, right? So
Yeah.
yeah,
A crisis or
yeah,
something, you
yeah.
know. Um, Last question. If we could study the brains of people harmed by psychiatric medication, do you think we would find anything? Or is this not really going to be a structural type thing? It's more of a functional thing, in your opinion?
Um, I think it's more of a functional thing. So I don't think, but I don't think it's, I wouldn't dissuade somebody who wanted to do autopsies and study the brains and try and identify
Mm.
um, particular flags that would, but I think it's more likely to be a functional thing. And it may be at some point we'll have a functional type brain scan that can be done that would be able to show what's happening, and that would be very useful if that was the case, because then somebody would be able to go and have that done and say, okay, well, this is why you're suffering as much as you are, and it still wouldn't solve the problem, but it would be a first step, I think.
Yeah. And I feel like somebody would just try to invent a drug or something that would
Right.
would be
Yeah.
the opposite, right?
Yeah.
So, yeah. Well, on that note, on inventing drugs, I guess I'll just say to close, do you think there's any hope for this? Are we seeing anything that, makes you feel like we're moving away from this harmful practice? Or do you think we're always going to be there with medicine and it's up to the consumer to protect themselves?
Well, I think there is a growing number of people who are looking at. I went to a conference in Calgary just this last year. It's the Preventing Overdiagnosis conference,
Mhm.
and those people are really looking at preventing overdiagnosis and overtreatment, and it was a good conference, and it wasn't being funded by any drug companies or etc. So,
Yeah.
and there's a movement in both Canada and the US called Choosing Wisely, which is also a very good movement. And if you have a physician who's involved in that, then you can feel like they are going to be better equipped to choose wisely for you and help you with that.
Yeah.
And the Lown Institute in the U.S. as well is also looking at these issues. So there are movements that are occurring. So let's hope that.
Yeah. That is hopeful.
Yeah.
I know I said last question, but one more thing popped in my head that I want to get from you before you go. You've read Bob Whitaker's book, Anatomy of an
Yeah.
Epidemic. Yeah.
Definitely.
Do
Very
you
good book.
agree that psychiatric medications might actually be causing mental illness and disability from mental illness?
I think there's a very high likelihood that that's the case.
Yeah.
That the epidemic of mental health disability in North America is being caused by the drugs, not being prevented by the drugs. Yeah.
Yeah.
Unfortunately. Yeah.
I agree. From someone who took them and knows what they did to me and the type of mental illness symptoms that they caused,
Yeah.
and from all the countless thousands of people that I've talked to who had similar experiences. But yeah, so
So if there was, if somebody could run a trial, right, and
mhm.
where where they randomize people to standard therapy, which we all know is using lots of drugs, um,
Mhm.
and and the other group would be minimizing the use of drugs and using them only for short term.
Mhm.
And if we randomized 1,000 people to those two approaches, and we followed them for 5 to 10 years and found that the people who minimized the drugs did much better in terms of long-term um, mental health problems and other problems and hospitalizations, etc. Then maybe that kind of evidence, if it was published in the New England Journal, would start to change people's approach.
Yeah.
So I think that's the best chance of reversing this phenomenon. Yeah.
Yeah. Well, hopefully there's some young whippersnapper out
Yeah.
there with lots of money or some funding behind him that wants to run a study or trial like that, because
Yeah.
it's so needed. I agree.
Mhm.
Well, thank you so much, Dr. Wright, for joining us. Do you have any, closing thoughts or last things before we go?
No, it's a big problem, but yeah, and I thank you for continuing to get people thinking about it. So, and medicating normal is a great documentary for everybody to see.
Yeah. Well,
Recommend it.
thanks. Yeah. I wish we could clone you like a million times. I know everybody in Canada does too. I get emails all the time, people wanting a doctor in Canada. So yeah, hopefully, some of them will see some of your work and maybe be inspired to, you know, take the
Yeah.
torch and yeah. So
Well, I'm working with some younger doctors right now, so maybe some of them will get the time to do some of this going
yeah.
forward. Yeah.
All
Yeah.
right. Hope so. Okay, well, thanks everybody for tuning in and joining us for this live discussion. If you haven't seen Medicating Normal yet and you'd like to, you can go to medicatingnormal.com/watch for the many ways you can rent and buy it. You can check our events tab on Facebook for more upcoming interviews like this one. And lastly, if you'd like to support our outreach efforts to bring the film and more conversations like this one to communities worldwide, you can make a donation at medicatingnormal.com/donate, or you can support us just for the cost of a cup of coffee at buymeacoffee.com/mnfilm. So thanks again, Dr. Wright, for joining us. Thanks for our listeners, and I'll see you next time.
Okay,
And
thanks.
keep in touch. All right.
Been a,
Talk soon.
been a
Bye.
pleasure. Yeah.
All right.